On this episode of Plastic Surgery Uncensored, we're going to be speaking to world-renowned expert Dr. Shirin Tofai about hernias. Everything you need to know about hernias, from mesh to complications. You definitely want to tune in and check it out. All right, welcome back to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Hernia Repair, and this episode is going to be really fascinating. At first, you would think, how fascinating can hernias be? But I assure you that Dr. Shirin Tofai, who is not only a world-renowned expert, and I don't just say that loosely, she really is world-renowned, is a dear and close friend of mine. So that makes this conversation even a notch more fascinating. Welcome, Shirin.
Thank you, my dear Dr. Raban. I appreciate it.
Okay, so let me explain to our listeners why the hell we're having this conversation. Because I do an extensive amount of abdominal wall reconstruction. Every time I do a body lift, every time I do a tummy tuck, an extensive part of what I do. In other words, wow, holy shit, look at that woman. Look how good she looks. Half, if not more, of what I'm doing is abdominal wall, addressing the abdominal wall musculature and things of that nature. You can't get an amazing torso or an abdomen after a tummy tuck or body lift and not address the muscle layer. It's not just a remove the skin and cut out the fat kind of surgery. That being said, you have devoted your entire life to the specialty of hernias, and as a result, pushed the field of hernia surgery to the limits. And we would be remiss as colleagues not to have this dialogue, because there's a lot of confusion, and understandably so, because the medical community is confused, let alone the layperson, about what's a hernia, what's diastasis, when the hell do I need mesh? Mesh will kill me. Mesh is good for you, and so on and so forth. So if you're listening, you can't get a better person to give you some info on this. So why don't you tell me a little about how you ended up going from general surgery to where you are now regarding your specialty?
Thank you for inviting me. It's really a pleasure to be on this. I do listen to all of yours because I'm very interested in what you do, and I learn from it because so many of my patients either talk about, the options of plastic surgery versus what I do. And you're absolutely right. What you do with the abdominal wall is a lot of reconstruction. I deal with hernias. Hernias are a little bit more than just abdominal wall problems. It's an actual defect. It's a hole in the abdominal wall muscle. That hole may be there for another purpose, but if it's there and it either causes pain or there's something that falls into the hole that shouldn't, like intestine, then that demands repair. And that is not considered a cosmetic or it's considered elective, but not cosmetic surgery.
Yeah, and I think one of the things that you touch on, so let's make some definitions right out of the gate. So first thing we need to define is the distinction between a hernia and diastasis. Yes. So as you had said, a hernia is a frank opening, a hole in your abdominal wall. That means there's an actual hole, tissue is missing, and contents, whether that be fat or intestines or anything, can go in and out of that hole. Diastasis, which is the area that I have focused and given my area of expertise, is different in that it may present to the average person on the outside, wow, I look like I have a bulge, it's a hernia, it's etc. It's different in the inside in that there is no real missing tissue, but the tissue you have, most notably in the middle of your abdomen, has been pulled apart and thinned out and has very little resilience or integrity to keep the abdomen from bulging out. So a typical diastasis patient is a mom, had a couple of kids, and with every increasing pregnancy, the muscles that hold them, the abdominal wall together, the rectus muscles, gradually pull apart. But not to the extent that there's nothing there, but the tissue that's there is super thin, atrophic, and kind of useless when it comes to abdominal wall strength. Your area is, there's a hole here, whether it was from surgery, whether it was from, it just developed naturally. It can be in the groin, it can be in the belly button, it can be et cetera, et cetera. So that's really a key distinction. And we work together in conjunction on many occasions, and why this is useful and what I wish would happen more often is this collaboration of fields, right? You send me patients, I send you patients, and often, which is my favorite time, we work together. So one of the topics that is huge is the idea of mesh. And I want to talk about mesh a little bit because I'm a very anti-mesh guy, and I'm only anti-mesh in and when it's used inappropriately. And like every other powerful tool, like a gun, like a knife, when it's used inappropriately, it causes chaos and havoc. And when it's used correctly, it can save lives. So let's talk about mesh a little bit. And I know you are on the cutting edge of creating mesh, and you have your own mesh design that's in patent, if not already done. So what is a mesh? What is it?
So a mesh is some type of scaffold or platform, usually off the shelf, but we use the term very broadly. Off the shelf meaning you just basically, it's not from your own body, that you use to bridge or help support a closure of a hernia. And not all, so as you said earlier, bulging can be a hernia, but not all bulges are hernias. My role is to determine if your bulge is due to a hernia or a diastasis or a nerve problem, and then to determine how to fix it and whether you need mesh to fix it. So in the United States, the standard of care for almost every hernia is to use mesh. Now there are exceptions to it depending on the size of the hole and risk factors, which we can get into later if you wish. And we're only talking about adults. In children, the standard is not to use mesh. But in adults, we consider the use of mesh to help support the repair of a hernia. By definition, we feel that hernias are diseased tissue. There's less collagen there, it's weaker, it's more of the mature collagen, there's abnormal tissue. And so purely closing that hernia, especially if there's tension on the closure, will just lead to failure and have it fall apart. Especially if that's already been proven by, let's say you had a surgery where they did cut and then close and then that closure open again. Now my training is very mesh dominant in general surgery. There are very few general surgery residency programs that teach you how to do a non-mesh tissue repair. Non-mesh repair. I learned in my residency and I learned since residency. In your program, your plastic surgeons, your really expertise in how to handle and manipulate the tissue to your needs. And in general, plastic surgeons are not very mesh dominant. They tend to either not use mesh or take advantage of as much of the manipulation of the tissues of the abdominal wall, or even bringing in new tissue to help support a repair. We just don't do that. We don't, it's just not our culture. And that's why mesh is so dominant in the hernia repairs.
So fantastic. So how I take it as is that you have a hole. So let's leave the diastasis world aside for a second. Right. So you have some kind of defect or opening in your abdominal wall. It can be small, medium, or massive. And depending on how big it is, that hole needs to be closed. So there are different ways that people can close those holes. And quite commonly, as you were alluding to, the most common way that is done in the general surgery world is to slap a piece of material, that material we'll get into later, to cover or patch that hole. Now, you can either repair the hole and then stick that patch on as a reinforcement, or in some instances, you can just use that patch as a bridge, which obviously is less desirable. And the issue at hand and why we even have, who gives a shit? Who cares about mesh? The reason we're having this conversation is that material is foreign. And like breast implants, where we just had an episode about BII, breast implant illness, the bottom line is the body doesn't like foreign crap in it because it's not designed to have plastic, metal, rubber, et cetera, silicone in it. And so wherever that is, and mesh is just one of those products, you have a host of individuals whose body will react in a bad way and then create other problems associated with that mesh. And that's why me as a plastic surgeon doesn't like it, because I see a lot of patients, as do you now, since this is your expertise, with mesh-related complications. If it's necessary, well, then it's necessary. Yes. But as you do, and the reason why you are on this show, and the reason why you are an expert, is that you, like most experts should, push the boundaries of what we're taught and find that in some instances, it's not as necessary as previously said. And there are other ways to do it. And what you have, I think, done an amazing job of is try to avoid the mesh in the instances it can be avoided. And what you do is what we do, which is you use the surrounding tissue and things like component separation and things of that nature to help do that. And I think that that's, I mean, obviously you're not successful accidentally. If you're doing what everybody else is doing, then you won't be successful because it's obviously has its issues to do with it. So that's why we're a big mesh. Now, where I come in as a plastic surgeon is obviously all of my patients are coming to me with some kind of, all the abdominal patients are complaining of some kind of abdominal contour issue. Quite commonly is an umbilical hernia. And I think that's sort of where we connect more often. Mm-hmm. And an umbilical hernia to me is just a term that people use that's inappropriate. They call it a hernia when in reality, yes and no. And the worst thing I can hear from a patient is, hi, how you doing, Dr. Bond? Great. I've had 3 kids. Okay, wonderful. I want a tummy tuck. Okay, great. And last year, 2 years ago, I had my umbilical hernia repaired using mesh. I literally wanted to throw up.
Yes, I agree. I want to throw up too.
Because
I just threw up, but you didn't see it.
It's a virtual throw up. It's an emoji throw up. I mean, what the? Oh my God. It's crazy because A, it's not indicated. 2, 99% of umbilical hernias are due to diastasis, not allowing that hernia is where your umbilical cord is coming out of your body. And so as a result, there's already a weakening. You have 3 kids and it separates, and I fix every single umbilical hernia, whether you ask for it or not. So that's where our worlds collided originally. But I think that's one area where we have some overlap. I'm going to take a quick break, and what we'll do is we'll come back. You'll define for me different kinds of meshes. Let's talk about where complications occur, and then let's talk about a little bit of our joint surgeries, because I think that's really fascinating that, like, you and I will get into surgery together. I'll help you, you help me, and we get through this. So
yeah, love it.
If you guys want to hear the rest of this, you better tune in. We'll be right back with Plastic Surgery Uncensored.
Yeah.
Welcome back to the second half of Plastic Surgery Uncensored. I am blessed and honored to have Dr. Shirin Tofai, whose information we will give you at the end, because if you suffer from anything that's hernia related, she's your go-to. And we want to talk about mesh because I think that's a big part of where our worlds collide. So tell me the different kinds of mesh. I know that you're in process of creating a patent on meshes. What kind of meshes are there, and what is the issue with mesh that forces you to find other mesh?
Right. So when we say mesh, we usually mean some type of synthetic product. It's usually flat, although there are different shapes and sizes. It's usually polypropylene based. Most companies that sell and develop mesh are polypropylene based, though there are
Which is options. Like plastic, right?
It's like plastic. Yeah, exactly.
So for the layperson, polypropylene is a fancy term for having a plastic net of mesh. That's if you envision like a netting or like a screen, a plastic screen, that's essentially mesh.
Yeah, it's basically a braided plastic, you can consider that. But it also comes in polyester and like Gore-Tex as well as another option. There are others in the available in Europe that we don't have available, PVDF, which is a polypropylene-like product. And, you know, it's expensive because it's developed by a company under strict regulations, but you know, in Africa and other countries that may be underprivileged, they even use mosquito net. So it's a synthetic product. It's usually a sheet or something similar to a sheet, and it's used to support a hernia repair. And there are newer options that are not synthetic at all, and they're biologic. So it comes from, let's say, a cadaver skin or fascia or
pig
animal's skin. And then there's the hybrid, which is a little bit of biologic and a little bit of synthetic, hoping that you bring enough synthetic in to provide that permanent hernia repair, but not so much to cause any adverse reaction to the synthetic part. And instead, the rest of it, the base of it, the foundation, is more of a biologic product.
Yeah. And so basically you divide into 3 components, as you said. One is some kind of synthetic plastic. Let's just call it plastic for the time being. One is biologic, which is human or life or tissue. Now, the biologic ones, it's important because we use them in many aspects of medicine. It's not really biologic in that it's alive because your body would reject it. It's the scaffolding or the collagen matrix aspect of humans and pigs and whatever. It's denuded of all of its cells, meaning there's no cells in it, but it's biologic in that your body will incorporate it and make it alive. And then there's this, as everything in the world is, there's combination. The next concern is, where do we put it? And so classically, you just slap it on top, and you slap it on top. So you fix the hernia, you York it together, and then you just slap a piece of plastic on it and you get the hell out. And why does that cause a problem?
I mean, it's a basic, all of what we do is very based on physics. So you want the mesh to be, just think if you have a hole in your ceiling or your wall and you ask for someone to come and fix it. So there's a standard. You want a certain amount of overlap with the hole. So you don't want a small mesh. Small is actually not good. And then you want to put it away from anything that it could stick to and cause injuries. So you don't want it stuck to intestines or bladder or the vagina or other areas where it's, I mean, that's those are different areas where mesh can go. But this is the issue with implants. And when we start inventing new products, which is, it sounds great in the initial, the whole purpose of bringing in some implant is because tissue repair alone was not good enough. A lot of morbidity with it. People were maimed. They couldn't walk. They were in the hospital for a week minimum. It was deforming in certain cases, because plastic surgeons were actually the ones that were reconstructing a lot of these holes before the general surgeons took over. But with time and with more experience, with more patients getting these, we're seeing the pros and the cons. And so the whole hernia surgery world is being tweaked a little bit to provide better outcome. Yeah. Can I make a comment?
Yes.
It just occurred to me. So you're calling mesh plastic, which is not disingenuous. It's pretty much what it is. But isn't it interesting that a plastic surgeon doesn't use plastic?
Yeah, because plastique is Latin for malleable. I just had a patient ask me yesterday. He's like, "Well, I don't get it. What the hell is this? What are you using that's plastic?" And I said, "No, we're not using plastic. It's plastique."
Yeah, plastique.
Yes, it's very no, we do not do that. So okay, so
we use plastic mesh, but you're a plastic surgeon.
Yes. So what patients and the people listening at home are like, "Oh, I guess this is an interesting episode. I don't really give a shit." Where they want to know is, okay, so let's bring it home for them, right? I am a person. I'm walking around. My belly looks really bulgy. I have some pain in my abdomen, and I don't like the way that it looks nor the way it feels. Really, that's the bottom line. And the question is, well, who do I go to? What's wrong with my abdomen? And that's where the diagnosis occurs. You could be overweight. Yes, you could be overweight and need to lose weight. It could be that your abdominal wall is weak from a handful of things like pregnancies and twins. It could be your abdominal wall is damaged from, I had a spine surgery and they went and nicked a nerve and now I have paralysis. Yeah. It can be that I have a hernia and I didn't know it. It can be, and all of the above.
Yep.
In other words, it could be a combination. And so the key to my big belly that is bulged and is painful is identifying individuals who specialize in abdominal wall surgery, who have the skill set to know what's within their lane and what is outside their lane. And so here is why when you go to individuals who co-collaborate, the beauty and the power of medicine. I don't do hernia repairs that are large and extensive. It's not my area of expertise, and I don't ever act like it is. And if I see a patient and I examine their abdomen, yes, I examine people. That's exactly the point. You can't just look at someone through a photo and be like, "Oh yeah, you need a tummy tuck." And during the evaluation, I identify or suspect that they have a sizable hernia contributing or as the cause of their abdominal issues. Then I need to refer that person to an expert such as Dr. Tofai. Conversely, I see patients all the time. This is the reason why she is an expert and an excellent clinician. And she will say, "Yeah, you might have a small hernia there or whatever, but that's not really your main issue." Mm-hmm. Your main issue is abdominal wall laxity, diastasis, etc. And you would be better served by having my colleague address this. And I may or may not be necessary, but this is not your main issue. And so you can see that you as a patient can't figure this out on your own. And you need to make sure that what you're talking about is being fixed by the right person. You don't have an electrician fix plumbing issues and you don't have a plumber fix electrical issues. And so Dr. Tofai and I do a lot of combined cases.
Which are so fun.
What's that?
Which are so fun.
Yes, they are fun because I never get outside of my bat cave. And whenever I get to be anywhere where there's other people, I always like to just talk and talk like that kid that never leaves his house. But it's great. And we do those combination cases. And I want people to understand that, because what happens is sometimes you'll go and you'll have it, you enter the line from different areas. Many patients enter the general surgery line, right, Dr. Tofi? You see people coming to you all the time, and their complaints are, my belly's large and it's bulging and I have pain. And I see patients that come to my office all the time. And what are their complaints? My belly is large, it's bulging, and I have pain. And they're the same patients coming into two different entries to the line. So how can that be?
I mean, the reality is that we're both able to dabble if we wanted to in each other's specialties. I can probably start sewing up a diastasis, and you could probably fix a hernia, but that's not really the right option for the patient. And I think a lot of reason why we see so many complications nowadays, especially with mesh, as you discussed earlier, is there are a lot of surgeons that dabble and they don't tailor the operation to the needs of the patient. And in not doing so, it's like a cookie cutter operation. Everyone gets the same operation. You have a lady who has a huge diastasis, had 3 pregnancies with twins, and has a small belly button hernia. That woman should not get a mesh repair belly button
100%.
hernia. She should get a diastasis repair. So, 100%. Yeah. So it's understanding what you do best and where your lane is, and then having a cadre of specialists that you can rely on, that you can either collaborate with or refer to give the patient better care.
I mean, I couldn't have said it better. And I think if you live in Cambodia, or if you're in the Congo, all right, that makes sense. There's this guy does it all. He delivers babies, and then in the afternoon, he's doing your retinal surgery. I get it. But you're in Atlanta, you're in Dallas, you're in America. You have so many great options out there where the guy only does, or the gal only does X, Y, and Z, and you should be able to seek that care. And so I think that this is another underscore of what we try to constantly reiterate through the podcast, which is expect excellence and don't tolerate mediocrity. Average or good enough won't cut it. And complications do occur in the best of hands, but statistically, the probability of you having a kick-ass outcome is far greater when someone does something 1,000 times than someone does something 10 times. It's just the way.
Yeah, and I think the U.S. has excellent healthcare. Of course, there are spots in the U.S. where there's some lack of specialists, but in general, within an hour, you should be able to find a specialist in almost every town you live in. And I see a lot of patients that don't feel the need to go to at least a second opinion. I mean, surgery is surgery. You're having someone physically cut you under anesthesia. That's a big deal. And recurrences or complications from these operations are not a small deal. They're actually quite complicated, can make the situation worse. So I see a lot of patients that eventually make it to me. I am like the 3rd or 4th surgeon to operate on them, and I think what they thought was they were saving money, or they were being efficient by going to their local surgeon for a complicated problem. But I see a lot of patients out of town. I know you do as well. They come out of town because it's kind of botched. And I wish that they had the foresight to do their research. And especially now with COVID, everyone's doing telehealth. So there's no reason to say, I can't come visit you, because it's all via Zoom or some type of video conferencing now. But to invest in the luxury, which is their healthcare, to get the best care the first time, instead of doing 3 or 4 operations, which is expensive, and then ending up in my office to fix everything, or in your office.
No, and that's it. We live in a unique time. I mean, we have patients that come from Dubai and all over, and those patients say, first and foremost, is the idea of not inquiring is just foolish. Saying I can't afford to fly somewhere and get it done, I respect that. But the idea of not even inquiring, paying $300, $400, $500 to get a consult, to say, well, okay, but the guy in my city said I need X, Y, and Z. What do you think? And then you say, well, holy shit, I would never do that. You wouldn't? Not at all. Oh, crap. The minute you get one guy saying one thing and another guy saying another, do you know what you need to do? Get a third opinion.
Yes.
You know what I mean? Like if someone says the answer is X and the next guy said the answer is Y, you better find another person, because there should be not that big of a discrepancy between approaches and thoughts. So the take home message today, specifically, abdominal wall issues can span from plastic surgeons all the way to general surgeons. And the only way to know is to do your homework. And B, and I think Dr. Tofai brought a great point up, is at least if you get the sense that you're not sure, but even still, even if you think the person walks on water, you should always get a second opinion. And that requires for you to dig a little past the local area and maybe find experts in your area, in the world, even if you don't end up going to them, even if you just get information. So, Dr. Tofai, where can people find you? So what is your, what is your IG address? What's your handle?
I'm at Hernia Doc on both Instagram and Twitter. It's Hernia Doc.
At Hernia Doc.
Mm-hmm.
That's where you find her. She's the woman. Dr. Shirin Tofai. All right. Well, thank you so much for participating. I know you're a busy woman. You're probably about to get off this and go on some teleconference in Korea or something. I hope this was interesting to people. I know for a lot of people, they don't really know what hernias and that is not about, but I think you can get the gist of how this can apply to other areas. So thanks again, everybody, for tuning in to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Roddy Ron. Make sure to tune in next week, because I'm sure whatever we're talking about is going to be interesting.
Thank you.